We had our launch seminar back in January, and if you didn't make it to that and you're interested, there is a recording available of that, which we can send you a link to. A little reminder about this working group and the aims and objectives of it and why we set it up. So we've brought this group together to try and help foster a sense of community and shared learning and knowledge about how we might use human factors and ergonomics in practice in the patient safety research network. And as part of that, we are hosting these quarterly seminars. We're going to have an in-person event in July in Leeds. Further details of that will come at the end of this session. And we are inviting speakers from research and practice in healthcare, but also from other disciplines and industries as well. And we want to broaden our network and make sure that we've got lots of opportunities to learn from each other and develop opportunities for further learning and research across the network as we go. So for this, our second seminar, we have got Chris Elston joining us. Chris has got a beautifully varied career, having started in the Navy as a medical assistant. He's worked on submarines, now works in Southampton, and having worked in A&E and done various clinical roles, is now with the education team helping to support the patient safety agenda down in Southampton, and is going to talk to us today about how they've been using AxiMaps in their practice and in their education and safety teams in their hospital. So I'm going to stop sharing my screen in order to give Chris opportunity to share his, and over to you, Chris.
Thank you very much. Yeah, as Brooke said, I'm currently the patient safety education lead at Southampton, and I believe that I'm the only one in Hampshire whose role is directly education and patient safety. So I've got a quick presentation that I shall share and we'll go through, and then I'll take questions and hopefully spark a discussion at the end. So I'm going to talk to you about AxiMap, and my plan for the session is to give you what my introduction to AxiMap was, the development of AxiMap here at Southampton, and a couple of examples of where we've actually used it, and then a very brief personal thoughts about benefits and disadvantages. So that's my idea, probably about 15-20 minutes of talking, and then hopefully discussion. So my introduction, I suppose human factors introduction was when I first went to sea on a submarine. Obviously, we've got double redundancies to make sure we can get back up on the surface. But I didn't really have any knowledge of or awareness of what they were. It's just the safety stuff that we did. Working within a team, training within a team, all those sorts of things. I then became a nurse, wanted a career for when I left the Navy. So I became a nurse in the military, and was unfortunately involved in a patient safety incident, which opened my eyes a little bit for how people were treated, the level of blame that people received. And at that point, I decided that nobody in my vicinity who made an honest mistake would ever feel the way that I'd been made to feel. So I kind of fell into an interest in patient safety. I did a bit of looking around at human factors. It was very high in the RAF, but not quite so high in the Royal Navy. Went out, left the Navy because I got too cynical for it, too old, and went and became an A&E charge nurse. Carried on reading around human factors, and then a job opened up where I was a bit more governance related. Did a bit of study, completed a PG dip in applied ergonomics and human factors, and then this job opened up and away I went into it. And when I came here, this was where I was first introduced to AxiMaps. And it was basically the first couple of days that I was here when somebody said, we run an introduction to patient safety incident investigation course. It's one that you're going to be managing, so you best get on it. And part of the pre-course reading was this animation, the award-winning animation. And it gives you this at the end of the video of an incident, and it made sense to me. It was really simple to understand. So I could understand why the decision had been made at Southampton that actually, if we're asking people who aren't experts in human factors to look at interactions, we need to try and make it as simple as possible. So this was the way that they were looking at, but they'd also simplified it a little bit, and they changed it so that it was only a few levels. So you've got your government external factors, organisational hospital management, technical and operational management, which is reduced down to job or workplace, and then your physical individual factors and outcome. And we use it with a scenario within our training. So we've got a couple of scenarios we run at the moment. One is a hard of hearing gentleman in a waiting room. It's a bit noisy, goes to the wrong bay because he mishears his name. He ends up having some wrong site surgery. And there's lots of other factors around that. And the second one is a learning disabilities lady who's newly diagnosed diabetic who ends up having a hypo because there's a problem with the way that the drugs are administered. But what we wanted was to make it as easy as we could for clinicians to look at it and understand what we were looking for. So whilst we were still post that immediate period of time post-COVID, it was all done virtually. It was all done on Teams, breakout rooms, using Google Charts, Jamboards, that kind of thing. And it felt like it was very, very difficult to get people to engage because obviously whilst people are on Teams, there is a temptation to do other bits and pieces. So we brought this very much back into the classroom as soon as we could. And found that actually being face-to-face that improved what we were teaching. And this is some of the initial output that we got. And as you can see, we've do it on a flip chart. We've slightly changed it. It's now post-it notes so people can change the locations because there's always a difference of opinions about where they go. But looking at it, I felt it was still very much just a list of factors. There wasn't sufficient interaction and identification that was happening. Although having said that, when you get a room full of biomedical scientists, they tend to start making those interactions much quicker than anybody else. And I think that's because of the nature of their work and the way that they think around it. So we thought, need to show people how it works. So we devised a little bit of a teaching tool, something that most people in the hospital can understand. So a patient falls over. Let me just ask a series of questions. Why does a patient fall over? Well, they wanted to go to the toilet. They've been told they're not to walk without any assistance, so they ring the buzzer. The buzzer's not answered, so they decide to walk to the toilet. They've been told they need a Zimmer frame, but it's stored at the end of the bay. So the patient decides to walk to the toilet, falls over. But you can now start to look at where some interactions may be. If you look at the Zimmer frame, why is it at the end of the bay? Because there's not enough Zimmer frames in the ward. So it's one Zimmer frame for as many patients as can use it. And why is that? Because the hospital budget isn't big enough. And again, interaction now going up into the government, the NHS budget isn't big enough. And it probably never will be big enough. But equally come back to the buzzer. Why wasn't the buzzer answered? Because we're short-staffed. Why are we short-staffed? Because staff have been redeployed to other areas. All right, so we're creating 2 amber areas instead of a green and a red, which makes sense. It's the lesser of the risks. But that also then links into the hospital budget because we're trying to reduce the expenditure. We're using in-house methods rather than going out to bank and agency staff. And equally, at the time we wrote this, there was a lot of industrial action going on with junior doctors, nurses going on strike. So it may be that they've been redeployed because there's industrial actions happening across the country. So again, an external factor. You could also look at your short staffing and go, well, actually, the media tell people that healthcare is not an attractive place to come and work, and we're seeing reductions in applications, so therefore we're finding it harder to recruit. You could also turn around and say there should have been some sort of assessment, and SURFIT is just our in-house assessment of falls risks. So the SURFIT wasn't completed. Why? Because we're short-staffed, and then that links in. So you can see how simple it can be to put together an action map. And the good thing is, most people will be able to put things into the places where they think it's best suited. Another good thing about ActiveMap is you can start to see where you can make interventions. So it may be that we need to use our staff a little bit differently. Maybe we need to look at our rota periods, our shift patterns. Can we use our staff in a more effective way? Can we convince the director of finance to actually give us a bit more budget to buy some Zimmer frames? Maybe we can look at where the Zimmer frames are stored. So you can actually see where you can make interventions. So what else have we done? Well, the development of actually using it, we went live with PSERF in 2023. We had a really nice launch ceremony and everything planned. Unfortunately, the BMA put the junior doctors, as they were at the time, on a course of industrial action for that week. And we were very much relegated out of the newsworthy stakes. So we had a very, very quiet launch when we went live. We changed the terminology. We expected to see a change in methodology, but we weren't sure how long that was going to take. So it wasn't evident to begin with. So again, with my educational head on it, I thought, you know what, we need to do a little bit more coaching. People are happy to make a change, but they're not happy to be the first. They're not happy to do it unsupported. So we started to introduce some masterclasses. And again, it's that change, isn't it? Whenever you're trying to change anything in a big organisation like the NHS, it's almost like trying to steer an oil tanker or the Titanic in the middle of the Atlantic. It takes a while. So the introduction of these masterclasses weren't so much changing terminology, but changing what we're doing. And the good thing is, after about 3 or 4 of these masterclasses, we're starting to see ActiveMaps appear in our patient safety incident investigation reports. And we take a group of people, multidisciplinary, into a room and somebody brings a case. And we get something like this. So this is a patient who had a retained wire during an operation. And you can see how they've come to this. We've got a retained wire that might have been due to stress levels rising due to operational complications here. But that might have been the stress because when they opened up the sets, it was the wrong set for the first patient on the list. So obviously increasing their stress. But we can link that back to the operating list ran over. It's a very busy, crowded operating theatre. So that again increases the stress. The incorrect wire was used and it broke during the operation. More stress. We've had a changeover of staff that might have been because of the list running over, but also where does that fit with our swab count policy? Did they do a full swab handover? Cut, broken and complete wires are not included in the counting procedure. Something that nobody other than one of the ODPs that came on the masterclass could verbalise. Everybody thought if we put it in, we take it out, we'd count it. Right. So you can start to see all these interactions coming up. Right. We've now seen that because of this, IHSS, which is our sterile services, are supplying photos with the loan sets, because this particular set that was involved had over 200 bits of equipment, that asking somebody to count that and check that before the operation was probably unrealistic. So the best we could do now is to have a look at the photograph and see if there's anything glaringly wrong with it. Similarly, if we went to gynae, they've done their own ActiveMap again, based from one of our masterclasses. We had a retained swab. It was a failure of the swab count, we think. But again, we've identified who's responsible for doing a swab count in a maternity procedure. It wasn't clear from what people were saying during the discussion who had that line of responsibility. Was the midwife unaccustomed to a flattened hierarchy, which is something that maternity have worked really hard on having? They've got a very, very good supportive network over there. What support's available for our junior midwife? Does that impact in any way? It's particularly about the experience, the ability to challenge. Again, when we come up, we've got a whiteboard. This has now started to cause people to look back in history a little bit. And the whiteboard was an intervention from a previous similar episode, but because staff have changed over, this was 3 or 4 years ago, the whiteboards are there, but the use has eased off. So they're now looking at what stopped them. And whether or not staff changes in the room, again, does that mean that there should be a full brief? Because this isn't a major procedure like something in operating theatre. This was a local one, a minor procedure. And then we're looking organisation care group, how do we embed the learning from our cases? How do we share it and swap it around? What's the division of workload? So again, a nice pictorial representation of some contributory factors. So my idea of some of the benefits and disadvantages, it's a pictorial representation. It's very easy to pick out parts from it. I think it's really easy to use for novices. We see this with some of the student nurses that come through our team on placement. We take them onto the course, they start to use this, they find it very simple. It's an easy, simple way for non-human factors people to grasp the interactions of environment, tasks, workload, people. And you can directly link those interactions to outcomes. It's encouraged, or we at least encourage, a multidisciplinary team approach. We've had in the room where that previous gynae AXIMAP was, we had an anaesthetist and an ODP who compared it to the way that they would do things in theatre, which gave people an idea of where to look, and also some of the interventions that could be put into place. I also think we can use it as a living document. So as you interview people and get more information, you might put more information on it and see further changes, and you can use it to plan the investigation. So disadvantages, as you can see from the beginning, it's really easy to get just a list of factors, no interactions. People feel very comfortable putting things down on a piece of paper. They're less comfortable trying to find those interactions. One of my colleagues described it as far too messy for her brain. So it is easy for it to become too crowded, difficult to see multiple interactions, as you saw on some of on that, particularly that second AXIMAP, it was harder to see. For me, I think the idea would be to have an investigation room like they do with crime scene investigation or air crash investigations, where you have a perspex screen you can write on it, and that screen can be as big as you want it. There is a time requirement. Our masterclasses are roughly 2 hours, probably takes about an hour and 15 minutes to get most of that information down on paper. So there is a time requirement, and trying to ask people in their busy days to find that time is quite difficult. But I think for me, the biggest problem, and I think it goes for most investigations, is it's far too easy to lose yourself if you don't have well-written terms of reference. You can find so many little rabbit holes to go down that you end up stuck in a labyrinth and trying to solve every single problem you come across, instead of focusing on what might make the biggest difference. And that's my presentation. I think discussion and questions, I've left my contact details on there. And I've got some further reading afterwards, and I'm happy for you to have the slides and share them so that reading, those contact points are there. But I'm open to questions now.
Thank you very much, Chris. Really, really interesting, and I'm particularly pleased to see that AXIMAP is getting used. People will know from the other webinar that we've done that I do like SEEPs as a tool, but it's not the only way to look at your system, and I'm quite an advocate for AXIMAP, so I'm really glad to see that it's getting used in practice and being so well received as well. So I shall go to the audience for questions. It looks like Bryony has got her hand up.
Thank you. Yeah, it was really interesting, Chris. I'd heard of it, but not seen it sort of illustrated in this way before. So that's really helpful. I think the question I have in my head is I'm trying to reflect on how it compares to some of the other tools that we might use that perhaps draw on human error theory, for example. So I'm thinking of things like Reason's accident causation model, or the Yorkshire contributory factors framework, or even sort of fishbone diagrams and things like that, because it strikes me that all of these have got you know, encourage you to think about these different layers of the organization, the team, the individual task, etc. And I just wondered if you had any thoughts on the pros and cons of this specifically in comparison to some of those human error type tools.
I'd have to say I don't. I've never really used a fishbone diagram. In fact, doing my course this year was the first time I've ever had to construct it, and I don't see a huge amount of benefit from one to the other. I think if you used either, you'd get similar sort of information. And I've never used the Yorkshire Contributory Factors framework.
I wonder if others have used, it sounds like some people on the call have got experience with using AxioMap, and I wonder if you've also got experience with using the other tools. Because I sometimes wonder whether we all go to our go-to. Like, I really like Reasons Accident Causation Model, so that tends to be my go-to. And partly what I'm wondering is, well, in what situations should I try doing something else like AxioMap or something else? And I suppose I'm thinking about, if I'm going to add more tools to my toolkit, which one should I use where, rather than, you know, that, what's that phrase about, if you've got a hammer you think everything's a nail to bang in, right? So I'd love to think about how I can expand that. So yeah, really interesting. If anyone else has used
on that, the ODP that I was talking about, she finds AxioMap really difficult to use. It doesn't fit with her thinking patterns, so she finds SIPs much easier. And at the moment, I think our expertise in human factors in Southampton is limited. We haven't really got anybody who's gone away and done massive amounts of study or has a graduate qualification in it that I know of. We've got a couple of people, anaesthetists, who've done a bit of work with Terima, but they seem to focus very much on crew resource management, human factors, rather than the whole gambit of environment and everything else. So I think at the moment, I'm inclined to tell my guys, use whichever you're most comfortable with, and we'll see where we go.
Thank you.
Probably doesn't answer your question very well.
I think the point was to stimulate discussion rather than expecting an easy answer. So thank you.
Thank you for the question, Bryony. Ruth, have you got a question or a comment to add on to that discussion?
Just a comment, I think. Although I did have a question as well, but I suppose I wonder whether it depends a little bit as to what you're wanting to get out of using the tool. So I could see that AxioMaps might be really useful for really explicitly being able to show how different levels of the organisation or kind of the structure might, it gives a very visual representation of that. If you were looking at interactions, potentially FRAM might be a better way of doing that. It more easily or more explicitly highlights those interactions. The Yorkshire Contributory Factors framework breaks down each of those different elements into much more detail, so might allow a much more nuanced kind of categorization of factors that impact. So I just wonder whether, I think we're quite used to in healthcare, and I say this not being a clinician, but as a researcher, it feels like we're quite used to in healthcare organisations just using the tools that we're trained to and used to using without really very much critical thought as to why we're using it, or even awareness that there are other tools that we could use. And so maybe just thinking about which tool's the best for the thing that we're trying to, what we're trying to do would be a better way. But again, there's not much, as you just alluded to, Chris, there's not much kind of human factors expertise.
I think there's a real problem with the introduction of PSEF in that it's a really good idea, and I think it's a massive opportunity to improve patient safety beyond recognition. I'm not sure the level of support and expertise was provided at the time. Because everybody's talking about FRAM. We've seen FRAM a couple of times. I can't get my head around FRAM. I can't even decipher a FRAM at the moment. So that's on my list of problem-solving things to find out about. But I do this patient safety day in, day out. So if I'm asking clinicians to identify a tool, I'm not sure they've got the expertise. A colleague of mine has taken the opposite opinion to you, Ruth, of actually SEEPS is really good for the local stuff, looking at a single individual procedure, whereas AxiMap is much better at looking at a strategic level thought. I think you can do both with both. But again, like I said, what information are you looking for? What you're looking to get out of it would be more about which tool would you choose. But yeah, I think FRAM's got a lot of potential advantages for what we do, particularly the level of interactions and the management decision making that we see within A&Es, AMUs, and all those sorts of areas. But it's not even mentioned in the toolkit for PSEF.
It's like we've just switched from RCA to SEEPS.
Yeah.
Sorry, personal opinion. I was just wondering as well, Chris, in terms of AxiMaps and your experience of using it within the trust, have you noticed any difference in the kind of impact it's given you to be able to have some of those conversations at a higher level in terms of releasing more funds? If you're able to picture, like visually really show some of those, has that helped you in any way?
The conversations have changed. The results are pretty much still driven by what's available on the budget. I haven't seen any increase in funding or release of funds to projects. It's very much still being dealt with. What can the local area do? I think there's probably three paths of work within healthcare. One, the local stuff that the ward can do or the department can do. Two, stuff that's a little bit more difficult that requires care group or divisional input. And then it's too hard to address pile. And that will never get done at the moment. And those are the things that, you know, probably the interaction between us and the ICB and us and Portsmouth or Hampshire hospitals, trying to get that joined up thinking working, which is still quite novel to be talking to everybody around us.
Looks like conversations are changing.
But the conversations are changing. We're now starting to have much more definitive conversations in our oversight group about, okay, where does this sit? What can we do? Do we need to be aware of this? And conversations are happening much more about capacity and trying to fit more patients through a fixed window. So I think it's changing, but like I said, it's an oil tanker. It's not going to turn very quickly. I think 3 to 5 years probably be an expectation to start to see some meaningful change.
Thanks, Chris.
Thanks.
Thank you very much. Adam.
So thanks, Chris. That was really, really interesting. I like the way that the discussion ended up moving towards the comparison of AxiMaps and FRAM. So as somebody who uses FRAM fairly regularly, FRAM's actually really useful for really understanding the drivers for the interactions between the different components, which I can't see that understanding potentially emerging. Sorry, my cat wants to join us. I can't see, and having used AxiMaps a couple of times in simulation settings, I can't see the depth of that understanding of the drivers of those individual interactions and the impact of something up here affecting something further down the line. I don't see that through AxiMaps. So that's been interesting food for thought, the comparison of actually what you're trying to do and what Ruth was saying, what your approach and what your aims and objectives are would help you select that. I suppose my question is, and it's something that's been fed back to me by other practitioners, there's a concern, I think, with AxiMaps that it becomes very easy to just become disincentivized by, well, everything's related to the higher level, the policy decisions, the government decisions, which then create, or rather, I suppose my question would be, do you find that in practice when you're using this in reality? Do you find it easy for people to just pass the buck further up to people who aren't in the room? And if so, how do you mitigate that?
I do find that there is a tendency to look much further up and out than there ever has been.
Mm.
I think people are now much more aware of decisions being made higher up the chain of management, command, whatever you want to call it, and how it has an effect. But in reality, when you're starting to look at the interventions, they're still looking very locally about what they can influence to make the change, to make it safer. I don't think many of the sisters, in particular, the sisters in the charge nurse level, feel that they can increase their sphere of influence enough to make the care group management aware.
Mm.
So we're still seeing very much the low-level posters on toilet doors, tell people to be careful, make people aware of the incidents, rather than going that step further up and saying, well, actually, we've got a dose area reducing software on our pumps, let's use it. Which I think would be the systemic factor and a big change.
So who are your participants then on your modelling? When you do this in practice, who is in that room when you're doing that exercise together?
It's generally people from divisional governance, people that have been involved in the incident, and then maybe a couple of consultants.
Okay. Is there a place then to bring in patients and the public into this?
I think there is.
Have you ever done that?
No, we've got our patient safety partners have gone through the training, so they sit on our new cases meetings where we validate the terms of reference, the tools to be used, how long it's going to take, and they sit on our oversight group at the end, but they haven't been part of an AXIMAP yet.
Okay. Thanks very much. Thank you.
Thank you. I've got a question related to that actually, is do you, where you've used AXIMAPs as part of an investigation, do you put them into your report or just the findings of it? Because I'm curious to know how that's been received by staff and also patients and families in terms of how they view the investigation and the findings of it that come out of it.
I think we've had one in a report that got really good feedback from the staff, from our seniors and our execs. They found it really simple to understand. I haven't had any feedback from patients and families. Our engagement is done by our patient safety advisors, generally, or the divisional governance team. And we're still trying to work a way out of getting meaningful feedback following the investigations. I'm not sure we've had any. So the gentleman with the retained wire actually gave us praise for the investigation, but I don't think the AXIMAP was in it.
It's an interesting, the rail accident investigation branch, which is the rail equivalent of the health services investigation branch. I know they use AXIMAP quite often as part of their investigations, but they very rarely put it into their actual reports. They use it as a sort of an analysis tool to help them get to their findings, and they do occasionally put the actual AXIMAP in. But it's just be interesting to see. I hesitate to say that maybe no feedback from patients is a good thing, that they've not turned around and said, "What on earth is this? I can't understand the report that you've put through." But yeah. Are there any other questions for Chris, either about how they've used AXIMAPs there or how they've been received, or any other questions about how they might be used elsewhere? Yes, Mohammed.
Yeah. Hi, Chris. Thanks for your presentation. So when I teach students on different contributory factors framework, AXIMAP is certainly one of the more popular ones alongside SEEPs by students. Much easier to understand than FRAM or indeed other systems-based methods. Students particularly like the fact that you can allocate accountability better, or at least the levels of accountability, and visually present it, as many of you have already alluded to. But one of the issues that I've had previously is that it lacks a generic classification scheme, so subcodes within each domain specific to healthcare. Is that something you've developed or you've encountered before?
No, we leave it up to the individual who's doing the investigation to place it.
Okay.
I think I'd like to see a national taxonomy. I think it would make it a lot easier to talk between education, research, acute, community trust, private providers. I think that would be really helpful. At least that way we're all talking the same way. But we haven't developed one at the moment.
Yeah, well, I'm not creating jobs for anyone here, but I think working groups like this could be a good platform to get such taxonomies going, really, at least to start the development or plant the seeds.
Yeah, Mohammed, I kind of agree with you. It's kind of the paper that I've dropped into the chat this afternoon. One of the elements of that study was that there was a lot of difference between the way people categorize different things within the two methods that they compared, which impacted on how well it was uptaken or how well it was likely to be used in practice. So I think you're onto something there. I think we do need to look at kind of these more advanced systems-based exploratory tools. We do need to look at how we apply those to healthcare, because they're not developed specifically for healthcare, therefore lack that kind of applicability.
I think PSEF was an opportunity to standardise as much of the terminology as possible. The conversations that we've had, people don't like the word interview, they don't like swarm huddles because they don't like the word swarm, so they've changed it to something else. So in Liverpool, if you said swarm huddle, their staff wouldn't recognise it as a term, whereas if you said to the Isle of Wight swarm, they'd know exactly what it was. So I think if that's with the tools that are in the NHS England's documents, then the actual contributory factors or the way we even describe some of the incidents will vary from trust to trust. And that makes it much harder to see if there's something we can learn from a trust up the road or up the country to save us doing the same job and duplicating the workload.
Thank you.
Thank you. And then Adam, you still got your hand up. Have you got another?
Yeah. So I was actually just going to throw something out to the wider group. As we're a research group who are looking to kind of tool ourselves up for human factors in research, what would we need to do with AxiMaps potentially to use it as part of a larger research process, as part of a larger research project, or is it a tool that we could use? And I think acknowledging Mohammed's comments earlier about the need for kind of that standardized taxonomy, what else would we need to do with this in order to use it in a future research project potentially, do we think? So that's chucked out to the wider group.
I think we need inter-rater reliability and validity analyses. I'm not aware of any having been done within healthcare settings. Paul Salmon from Australia has done quite a lot of work on AxiMaps, but in other safety critical industries. I'm not sure if he's part of his group, but Patrick Watterson and Thomas Young have done quite a bit of work on safety contributory factors frameworks and comparative analyses. But again, I think there is a bit of a dark spot has been healthcare, because all of those models come from other safety critical industries. They've been used in healthcare, but without the rigor that would traditionally be attached to other human factors based frameworks used in other safety critical industries. So I think that would be a starting point.
Thank you. Bryony.
Yeah, I think it's a great question, and actually completely agree with Chris and Adam's. Well, I don't know if Adam's comment was referring to this, but there's a lack of sort of evidence on reliability and validity for many of these tools, but I do think that is kind of what's needed to use them in research in particular, because at the moment they're otherwise a tool that people like using, but we don't actually know if doing a AxiomApp or doing a FRAM or whatever results in a system that is then safer. I think that's quite hard to demonstrate, which is probably why it's not often been done. But I know we did some work on failure modes and effects analysis, where we had two matched teams do an FMEA on exactly the same issue, and they came up with wildly different process maps, failure modes, scores, where they did come up with the same failure modes, they were scored completely differently. So it really did raise questions about the reliability and therefore the validity of that process. And I do wonder if there's some interesting research questions about how we can develop tools that give us the validity and reliability that we need to be really, really useful. But again, I'd love to hear what others think too.
Thank you. Ruth. You're on mute, Ruth.
Sorry, first fail. I'm not sure whether I'm being a little bit mad here or not, but I'm wondering whether I can use it in a different way in a study that I'm currently doing. So my understanding is that a lot of these tools are often used to investigate things that have gone wrong, so incidents that have happened, and to work out why. I'm just wondering, the study that I'm doing at the moment is in maternity. It's a kind of embedded research study, so essentially ethnography. And I'm just wondering whether I could use this almost as a way of, with a systems lens, trying to organise my data. So it's not really as an analysis tool as such in the way it's traditionally used, but just as a way of me pictorially trying to manage all of the data and the different interactions across levels of the system in order to look at how those things interact. So yeah, it's not a very traditional use of what it would be, but maybe something that could be helpful to researchers. And if I decide to do it, I'll let you know.
Adam. I'll let Chris come in first, and then I
was going to say, I don't see any reason why not. When you think SEEPS was initially quality improvement, we've enabled it for patient safety. And I think SEEPS is probably the only validated tool that was in the PCERF toolkit. I think the more we use it, the more people will see it, the more they'll get used to it, the more it's going to show its strengths. So I don't see any reason why you couldn't do it. I mean, we've simplified it here to make it easier for people to understand. We've taken some of the layers out. I know somebody puts context underneath it to allow you to understand the situation the decisions were being made in a little bit easier. So I don't see any reason why not.
Thanks, Chris.
Adam.
Yeah, I think that's really interesting, and those points you've just made there, Chris, really kind of useful as well. For me, it's about kind of human factors in a big chunk of it. It's about design, and is about designing systems to facilitate people to do the best job that they can. And I think, very honestly, we're not very good at the design part in healthcare. We're good at investigating. We're good at finding out what our contributory factors are. So I suppose AxiomApps, FRAM, what have you, have benefit perhaps in doing that initial identification, causal identification, contributory identification, but then perhaps it's a staging post to another piece of design. And then would we need another tool potentially for that design element afterwards to evaluate kind of the impacts of that design? Because I don't think AxiomApp or FRAM are particularly useful as proactive or prospective tools. And I'm happy to kind of be argued back on that. And it's what sort of kind of prospective tools do we need to use? Chris?
I'd agree. I think we're very good at putting an investigation together, but writing an action plan or coming up with some recommendations, I think, is the weakness within healthcare. It's very much that we'll take a view of what can we do to be done, and we value action before analysis on almost everything we do. We don't allow people to stop and think about what their action's going to be, what the impact may be, before we expect them to do it, or quick fixes. I mean, the phrase that sticks in my head from the 7 years I've worked in healthcare outside of the military is the number of quick fixes that we keep having to go back and refix because it wasn't the right solution in the first place. I think I'm a firm supporter of an investigation should come up with identification of weaknesses and frailties within the system, but then we go back to the workforce to say, what do you think? Is this a fair representation of your working environment? And how can we strengthen it? What have you tried in the past that hasn't worked? Can we modify that to something else? Or do we need to start thinking together about something completely different? I don't know about any of the guys on the call, but if somebody comes into my department and tells me how to work who's never walked a foot in my shoes, let alone a mile, I'm probably not going to listen to a lot of their suggestions. Might listen to them identifying the stuff that I no longer see as a problem, but to actually solve it, you need to understand what I'm trying to achieve.
I think that almost brings us back to Bryony's question about comparing AxiMap to other tools like Fishbone. And as I've used Fishbone with a lot of teams doing quality improvement and using it as the first step in the what is it we're trying to solve. And so something like AxiMap as the first step in that, this is going to help us understand what it is we're trying to work on. But there are steps that come after that in terms of identifying and testing out possible solutions and whether they're feasible in practice. Yeah, I think there's opportunity for AxiMap or tools like AxiMap, going back to Ruth's point about using them for different analyses and understanding of our systems. I've used one as an appreciative, doing an AxiMap. I don't have a good name for what you'd call it instead of an accident map, but and taking an instance where something went really well and using the same idea to map out at the different levels of the organisation what it was that enabled that really good practice to happen, to again shining a light on different elements of the system. And it's a useful way of, I find, of mapping different parts of it.
I think we need to start looking more towards a safety too of what happens normally and understanding that to a greater extent and trying to understand everything that goes wrong. I don't think we pay enough attention to what we do well. You know, most healthcare contacts, interventions tend to go okay, but we focus on the small amount that cause harm, quite rightly, because we want to try and prevent it. But I think if we understood our normal to a greater extent, we'd probably prevent some of those harm incidents anyway.
Have you, on that note, Chris, have you seen in using AxiMap, people have been better able to reflect about what was everyday practice and the circumstances, the factors that are those normal for that team, and what was different on the day? Is it helped you with any of that identification?
Not at the moment. They're still very much fixated on the one incident and not looking at it. I do find that going on observations tends to focus people on the everyday. We had an incident in theatre where a bag of fluid was connected to patient 1. They were disconnected and the same bag of fluid was connected to patient 2 in the next procedure. And nobody in the office could understand why that happened until we went up and watched what had gone on. And it was a culmination of a number of different events and decisions that had been made probably months before this happened. But because on this particular day there was one extra thing that hadn't happened, it allowed that incident to go through. Whereas before, it had probably been caught but never reported because it was a near miss. So, you know, our incident reporting takes about 30 or 40 minutes. Most people wait until the end of the day to put it in. So near misses don't strike the same thought pattern as a moderate or severe harm.
Yeah.
But
Very
yeah,
interesting.
I think the combination of tools is quite useful as well. Doing an AxiMap, and then when you get an interaction you're not quite sure of, go and have a look at it. Would give you a different perspective and probably a richer base of data to start basing assumptions and thoughts on.
Ruth, we'll take your question and then we'll bring the discussion to a close.
It's not a question really. It was just, I was going to say I just agree with that, Chris, because if you're trying to understand kind of work as done or the complexity of the environment within which you're working, AxiMaps, I imagine, wouldn't necessarily be the tool that you'd want to use for that. But once if you go through observations, interviews, etc., and do try and understand some of that work as done, some of the clinical complexity, etc., then AxiMaps might be a helpful tool to apply in order to try think about what influences those things at various different system levels and how you might be able to then address some of those things. So yeah, I think applying the right tool to the right thing is really important, as we all know.
Indeed. Thank you very much. Well, thank you very much, Chris, and thank you everybody for a really good discussion. I know I've had quite a few thoughts there about different topics that as a working group we can take forward and look for speakers to help us take these discussions forward. We're always very welcome for suggestions of topics, different speakers that people might be interested to hear from as well. I'll just finish off by sharing, hopefully so you can see that slide there with future events of the working group. So our next event is our in-person seminar on the 15th of July at the studio. Registration is now open. There's a link there. You can also do the QR code because I've been technologically fancy this morning. Please do register for that. We hope to see you at our event there, and we are taking abstracts for oral presentations. We don't have a particular format, but please do send your abstract submissions to me by email by the end of May. And then looking ahead after that, we have got lined up another couple of online seminars in the autumn, round about the 18th of September to be confirmed. We're going to have a session thinking about how HFE and safety equity align, where they can learn from each other, how we can use HFE to advance how we look at safety equity. And then in the new year, we're going to have a seminar looking at how HFE has been used to improve the PEWS procedures, the paediatric early warning scores. And then we are hoping that in spring next year we can have a SAMPIT event where we can have some really good discussions and take forward some ideas for proposals for future research for HFE in patient safety. We will share Chris's slides. I'm going to say thank you very much again to Chris for giving up your time this afternoon and giving us such a really good discussion. Pleasure. Chris is, as you said, people are welcome to contact you with any other questions and conversations. And yeah, we will see you all